In ectopic pregnancy, there are two main clinical presentations. Both patients usually have a history of amenorrhea for several weeks, and a pregnancy test is often positive. The first presentation is the stable, unruptured ectopic pregnancy. These patients typically present with unilateral lower abdominal pain, report mild vaginal bleeding, and on examination they are hemodynamically stable. The second presentation is the unstable, complicated ectopic pregnancy. These patients usually present to the emergency department with diffuse abdominal pain and shoulder pain, which occurs due to internal hemorrhage. On examination, there are clear signs of peritonitis, including abdominal rigidity, tenderness, and rebound tenderness. The patient may also report vaginal bleeding. Most importantly, this patient is hemodynamically unstable, presenting with tachycardia, hypotension, and altered mental status or confusion. The diagnostic approach is the same for both presentations. We start with a transvaginal ultrasound, which typically shows no intrauterine pregnancy, and in some cases may reveal an adnexal mass. Next, we measure the serum beta-HCG level. When the beta-HCG is above the discriminatory zone, which is approximately 2,000 international unit per liter, an intrauterine pregnancy should be visible on ultrasound. So, to summarize, a positive pregnancy test, no intrauterine pregnancy on ultrasound, and a beta-HCG level above the discriminatory zone confirms the diagnosis of ectopic pregnancy. Management then depends on the clinical picture. In the first stable case, we have time for medical management with methotrexate. If methotrexate fails or if there is a contraindication, we proceed to surgical management. In contrast, the second, unstable and complicated case requires immediate emergency surgery. Methotrexate is contraindicated in this situation, and this is a very important exam point. In this case, the patient has a history of amenorrhea and a positive pregnancy test, and ultrasound shows no intrauterine pregnancy. At this point, we are dealing with an ectopic pregnancy. The next critical step is to determine whether the patient is hemodynamically stable or unstable. This patient presents to the emergency department with worsening abdominal pain and reports vaginal bleeding. On examination, she is tachycardic and hypotensive with abdominal tenderness, guarding, and rebound tenderness. These findings indicate a complicated, unstable ectopic pregnancy. Therefore, the next step in management is immediate emergency surgery to treat the ectopic pregnancy and control the bleeding.